you so much for having me here, and a good evening to everyone. So I'm going to be focusing on our techniques on how and where we do our ultrasound guided injections, and I'm going to be focusing on the common upper limb scenarios that we come across. So of course, one thing that we need to understand is that ultrasound actually makes our life far easy because you're actually able to see all these structures, you're able to see the trajectory of the needle, you can avoid critical structures and do all of this dynamically. Of course, before we do it, we have to have proper sterile environment. And I like to always give a good amount of local anesthesia because that always makes the patient very comfortable and it just makes your procedure far easier. So starting with the subacromial subdeltoid bursal injection. So this is how the bursa looks on ultrasound. This is a normal bursa, sorry. Yeah, this is a normal bursa, this white line. And when you do get bursitis, this becomes thickened, or at times you can have this fluid, this black area which is accumulated over here. And when you have such a situation, actually your injection becomes much easier because you know exactly where you want to go and hit. So this is useful when there are cases of bursitis, there's subacromial impingement, we are seeing good results. So what we do over here is have this patient in a lateral decubitus position with the affected side facing upwards, and we do an in-plane approach. By that what I mean is I keep the needle along the long axis of the probe. So what this does is this really enables me to see this needle all throughout the procedure. So you can see that the entire length of the needle is seen as I come in and distend the bursa. So this is very useful when I want to move or change the trajectory of my needle. Now, calcific tendinitis is also something that we encounter quite frequently involving the supraspinatus, and calcifications can actually have different types of appearances on ultrasound. So you can have this very hard calcification with what we call as an acoustic shadowing, or sometimes you have this amorphic kind of a calcification. And it's actually these kind of calcifications, the ones in the resorptive phase, which may respond very well to the treatment. So there are a couple of things that we can do. One of them is an ultrasound-guided irrigation with a single needle. So what we do is, after giving a local anesthetic, we put in a slightly larger needle, probably around at least a 20 gauge, or ideally an 18 gauge. We attach this to a syringe, and the syringe is filled with the anesthetic. And what we do is give repetitive propulsive movements onto the syringe. So what this does is it actually breaks up the calcium, and this calcium comes back from the needle into the syringe, and you can, at the end of the procedure, quite nicely see that the calcium has come back within the syringe. And we can keep on doing this till we get clear fluid. There's another technique of doing it. You can have these two needles which are parallel to each other with their bevels facing each other. And once you inject the saline or the local anesthetic into one needle, it kind of comes out from the other. So you're kind of establishing a circuit. But personally, I prefer using the single needle technique. Now, coming to the glenohumeral joint injections, this is frequently done when there's a component of adhesive capsulitis. So I always prefer doing this posteriorly. So just a brief recap on the anatomy. This is the infraspinatus when I'm visualizing it posteriorly. This is my joint cavity, my humeral head here, the glenoid. And this white area, which is you can see over here, is the labrum. So what happens in this case is actually my space is very narrow. It's a little tight space. So what we do is keep the patient in a prone position. We ask them to abduct the arm and flex the elbow a little bit if required. So this helps to open up the joint space. And you can see that the needle is now comfortably going right into the joint space area, and we can avoid the labrum as well, which we have to. And once we start injecting, you can see that the joint space is actually distending. And this white area, what you see at the end, is a little bit of the air which was there in the syringe, which is kind of going into the joint space. Now, lateral epicondylitis is also a frequently encountered problem. We see that though the clinical examination here is very, very important, we can see that the tendon becomes very thick and edematous at time. And there are a couple of things which we can do. One of them is dry needling, which Dr. Lakshmi just touched upon. So what we do is with an 18 gauge needle, we do multiple punctures into the lateral, the common extensor tendon. and this promotes, it increases the bleeding and promotes the healing. Okay, and the other thing, what we do is once you're done with this, we always do a peritendinous injection. So one thing which I like to do when we do a peritendinous injection is put the bevel of the needle downwards. So what this does is it actually directs all your the steroid and the anesthesia, which anesthetic towards the tendon rather than it coming up into the subcutaneous tissues. Deca-veins, Dr. Parag has already touched upon, but what he does, I would say a little blindly, I would like to do this on with a guidance. And the advantage over here is that you are able to see a lot of these structures, which would ideally be a little difficult, with doing it blind. So you wouldn't really be able to see it. So in such cases, when the surface area is very small and we are visualizing these small structures, we use what we call as our hockey stick transducers, which are basically a very small transducer. So you can see that this is just nicely fitting on over the wrist, and I can approach, the tendon either from the medial or the lateral aspect. So when we do these injections, again, when the space is very small or there are very critical structures close by, I like to give a little bit of local anesthesia to kind of do a hydrodissection, separate out the structures a little bit, so you get a little better area for your larger needle to go in. Now, when we do an injection of this effect, we would want to make sure that the injectate is spreading across both the tendons, make sure that it's not only across single tendon, especially if the sheets are different. And here you can see that the injectate is spreading in very nicely. So post-procedure, always we explain the possibility of a steroid flare. We make sure that the patient puts in a lot of ice packs, avoids heavy exertional activities, and he can take whatever anti-inflammatory drugs. And we keep these patients on a follow-up. We regularly follow them up and see how they are doing. So it's important to explain to them that the effect is going to take place over a period of time. Right? So then there are these other things which we can possibly do. For example, this was a ganglion within the spinoglenoid notch, compressing the nerve. And as we aspirated, the patient was better. And this was actually just a case we had done 10 days back where we injected into a collateral ligament, and the patient got relief of symptoms. Thank you.